Hey, Peter.
Hi, Julie. How are you?
I'm well. How are you?
Oh, hanging in there.
Yeah,
Um,
pretty intense right now, right?
it's really intense. So I
Which
kind
is which is the most intense item that you have?
of, I think the just responding to all the requests around the COVID protocols. Whether it's cameras, setting up new units. This morning we've got tents everywhere.
Yeah.
Every clinic now has a separated COVID triage area, and just trying to maintain all of that and keep the sanity of everybody has been really hard.
Yeah.
Sure, you're going through the same thing, right?
We're going through the same thing, and then with the cybersecurity threat, there's just a whole nother crisis, right?
Yeah,
And so it's like nothing I've ever seen before, really.
yeah. It's I didn't have to, but they asked me to do an interview on Friday on the cyber threat against hospitals, right? And so spoke to that for a little bit, but it's like on top of everything else, we've got that to contend with, right? So every email now that every provider, every staff member gets is being questioned, or every little thing that's out of the ordinary is being, so it's just it's basically changed how we do work, right? And so, but yeah, it's
Yeah.
and just all the infectious disease controls that are going in place that we normally didn't have to contend with is, yeah, it's not a good time. And so I feel like going online here for an hour to talk about thought leadership around interoperability and all these things is all that's been kind of put on hold for us.
Yeah, you kind of put it to the side,
Yeah,
and you try to work on it as much as you can because that's the next thing around the corner. But we really have crisis every day,
yeah,
and we don't really. We can say in general it's around COVID and also cybersecurity threat, but the the challenges for us in terms of what gets on our plate every day is really different.
certainly, yeah. Staff is at kind of wits end. They're overworked, they're stressed, they're going through all of this, and then yeah, I don't know. It's we've had some really rough spots here
Yeah.
lately.
Yeah, we have to hold on. I'm gonna go. I'll step away for just a sec. I'll be right back.
Yeah.
Peter. Long time no see.
Yeah, how you doing, Eric?
I'm doing well, and you?
I've been better. I don't know when, but I've been better.
Can guarantee it, right?
Yeah, it's been a rough spot here lately,
Hear ya.
but I think we're doing okay.
Yeah. Hopefully, we're on the upswing here.
Yeah, I'd like to say that we peaked and we're on the other side, but I'm not sure.
Yeah, it's hard. It's a hard one to say. Soon, though.
Yeah,
Well,
gotta
have fun. What's that?
I said it's got to get better.
Yeah. It's a nice part of being at the bottom. It's gonna get better from here.
Right. Yeah, primarily that's kind of where we're at.
Right. Well, I'll let you go. Good luck.
Yeah, thank you.
So will we just be asked questions? I kind of put some stuff together. It's much longer than, I don't know if we needed to put slides together or not.
Oh, I don't know, Julie. I don't know that. I basically pulled out the last deck we did for the HIMSS conference because not much has really changed. But you know, I would like to see it be more interactive as opposed to reading from a slide deck myself.
Yeah, I kind of just did it at like 9 p.m. So,
Right.
And just to organize my thoughts, I thought, well, I could use it for other things probably, but I probably won't use it, obviously.
Right.
It would be way too long.
Yeah.
If I may, since you didn't ask for my opinion, I thought the HIMSS thing was good. If you had like a summary or a conclusion slide or something like that, you could almost start from there and encourage questions based on it.
Oh, yeah. You know what I did? I took the 3 questions that from Stephanie, and then what I did is I just pulled some stuff together, you know, to think about, you know, what to say.
Hmm.
Good morning, Julie. Good morning, Peter.
Hey, good morning.
Morning, James.
lost my pen. So Peter, are you able to get down to see what your son?
No, I haven't been down to Roswell lately. So we're
That's
doing everything
good.
quickly, yeah.
Yeah,
So, but Loveless has a hospital in Roswell, so I do need to, I can, parlay a business trip into to that also. So there's that.
yeah.
Hi, everybody. Stephanie here.
Hey, good morning.
Morning, Stephanie.
There we go.
Good morning, Stephanie.
Good morning.
Good morning.
Good morning.
Let's see here. We have a few minutes to start. Is Ava, Deb, or Mary on the line? Okay.
I thought I saw Ava join a minute or two ago, and
Okay.
then I don't see her now.
Okay.
Good morning, guys.
Hi, good morning. We're just waiting a few minutes till kickoff at 10:15.
No problem.
All right. I have about 19 different windows open right now between the PowerPoint and the questions and everything else. So, and all the 3 different windows that Zoom gives you. So bear with me. I also have a team of about 5 roofers on my roof right now, just banging away. So if you hear some unexplained noise in the background, that's what that is. But all right. Can everybody see the Experience IT slide with everybody's name?
Yes.
Yeah.
Great, perfect. Okay, well, let's go ahead and kick off. Good morning, everybody. Thanks for joining us to secure the future of healthcare. I'm really looking forward to picking everybody's brain today. I'd like to introduce our panelists. So today I'm joined by Peter Ames, AVP, Ardent Health Services, Loveless Health IT System, Health IT Division, which you may know locally as Loveless Health System. Peter's career has been centered around digital transformation and smart systems. In fact, he brought Albuquerque to the #2 digital city ranking in 2017 and the Center for Digital Government's top 10 for 5 consecutive years, which I'm sure was no easy feat. Recently, Loveless was actually also in the news for being the first drive-through COVID test site here in New Mexico and one of the first in the nation. So big shout out to Peter and the whole Loveless team for the great accomplishments and rapid response there. We're also joined today by Julie Bonello, SVP CIO of Presbyterian Healthcare Services, which you may recognize as our state's largest healthcare organization. And Julie's list of current and former advisory roles and board appointments to various committees are a testament to her active involvement in shaping the future of HIT. She brings a lot of knowledge and experience in many of the intricacies of what we'll be talking about today. And I personally want to thank her for being so passionate and engaged, particularly about regulation, which is not always perceived as the most glamorous part of HIT, as you can imagine. And last but not least, we have James Brown, CIO of Tricor Reference Laboratories and CEO of the Rhodes Group, which is the analytics subsidiary of Tricor. And his career has been hallmarked by over 30 years of all things IT, systems integrations, applications, security, enterprise leadership, you name it. And while we may all be familiar with Tricor as one of the largest reference laboratories here in New Mexico, I have a feeling you'll be hearing a lot more about the Rhodes Group in the coming months and years, with James and team leading new and exciting capabilities for the New Mexico Health Information Exchange, among other big things happening at Rhodes, I'm sure. Now, quick plug, if you're not familiar with our state's HIE, formerly called NIMHIC, but recently reintroduced as Synchronous, all caps, you can hear all about their roadmap and jumpstart on interoperability tomorrow at their Experience IT session in the afternoon. And as for me, I'm Stephanie Garadia. I'm the president of the New Mexico chapter of HIMSS National. Follow us on LinkedIn and Twitter for more panels and webinars just like this. By day, I'm co-founder of Versatile Med Analytics. We are all things business intelligence.
Which is great, to be quite honest, that we're doing this RFP for UNMHSC, because I am learning a lot more about what we actually have with Pure Cloud and how we're going to be able to utilize it.
Hi, Amanda. Didn't see you on there. Welcome. Let me mute you.
Apply that to some of our conversations we're having. I do think
unfortunately, I do not have panelists.
Thinking about how we develop a list of all the epic hospitals that have digital experience.
Can everybody hear Amanda right now?
Yes, yes, we can.
Yeah.
Amanda, stop it.
Amanda. Peter, if you, could you text her? I'm going to continue on with our
She just
our
went
intro. Okay, thank you. All right. Where was I? Okay, so yeah, by day, I'm co-founder of Versatile Med Analytics. So we're all things business intelligence. We work exclusively in healthcare and health data. And I love the role because I get to see how all of these efforts we're going to talk about today come together at the end of the day, ultimately to inform business decisions and moving the needle. Now, they asked me to kick off with a little brief description about a key term we're going to talk today. So interoperability, I think I might have already said it. I want to quickly define it, and I'm going to oversimplify it, and I'm sure that our experts here will add a lot to it. But interoperability basically just means 2 different health systems that can share data or talk to one another in a standardized and a preferably universally accepted format, whether that be through APIs or direct application integrations or so on and so forth. And the reason that it's important is because it enables access to patient records across the boundaries of the four walls of whatever health care organization you received care in, so that clinicians across the value chain can provide more informed, more robust patient care by having a whole picture of the patient's information, no matter where it occurred. And important to vendors like myself, it enables new applications to be developed on top of all of that great patient data that's contained within these very monolithic systems like our EHR systems, things like that. And while the technical component of interoperability sounds easy enough, like it's just an API, some of the major challenges have actually been things like all of these huge legacy health information systems like our EHR systems were really not always designed that way. And to top that off, there is a major lack of consistent standards, which leads to a behemoth in the room when it comes to integrations today. And that's the cost and the time. It's often very cost prohibitive, and often it's a huge all hands on deck undertaking across the organization. Then there's, of course, security and privacy concerns. Who owns the patient's data? That's more important now than ever. We'll talk a little bit about that. And frankly, it's a huge cultural shift. Organizations have not been mandated or regulated to expose this kind of information before, let alone how to make it available and in what format. So that can seem very daunting or really even threatening from a market perspective, as data, as we know, is increasingly being considered as a monetary, if not even a proprietary asset. So, a lot of folks may understandably want to keep that a little closer to the vest. Right now, there's a lot of healthcare delivery organizations and major health tech vendors that are under fire for information blocking. So in 2016, the ONC passed a rule called the 21st Century Cures Act, not to be confused with the more recent CARES Act. And the Cures Act seeks to regulate interoperability. Technically, everybody had until this month, November 2020, to comply, but it's now been delayed until February. And as Julie has explained to me, these new regs are major changes that could shake up the entire health information ecosystem as we know it. So, armed with that background to set the stage for today's conversation, I'm going to defer to our experts here to dive much deeper than that 10,000 level view. Please join in the discussion by typing into the chat. This panel is for you. I'll try to get any questions as they come up. So with that, let's go ahead and kick off. And my first question is for Julie, because I know you are so passionate about this. In my 10,000 foot recap, what did I miss? That's also really important for everybody to know here about interoperability in the Cures TEFCA Act. And how do you think that may impact anyone specifically here in New Mexico, whether that's patients, vendors, or healthcare organizations like yours? Oh, you're muted, Julie.
Sorry about that. This past May, final rules came out. One was called the CMS Patient Access and Interoperability Rule, and then the companion was an update to the ONC 21st Century Cures Act. What those two did, first of all, anytime now that a CMS regulation comes out for under the Centers of Medicare and Medicaid, what is embedded in those final rulings are HIT regulations now. That is 100%. That's a huge, big shift. So now HIT services are very much regulated with this new rule, it really sets the stage for how we exchange data. And when we talk about exchanging data, it's not just within the delivery side, right? It is supporting within your network of providers, just as we mentioned, but it is also supporting your payer provider integrations. And it actually now, the big thing that happened with this ruling is a new set of data. So on the health delivery side, you've got protected health information, PHI. Now with this ruling, you have electronic health information. That is allowing, with these rulings, the ruling said you have to now give access to consumers for their clinical and their financial data. So what's happening is there's a new electronic health information set of data called USCDI, the data and clinical data is being expanded every year. But what happens is a consumer can grant third-party access to continuously get this information from a consumer. That happens in 36 months from the date of the final rule. So what's going to now happen, and this is absolutely enormous, is it opens up an absolutely new area of health information technology that's based on the sharing with third-party vendors of EHI data. Now remember, EHI data will begin with a core set of clinical data, but then it starts to expand into claims data as well. So this will not only forge a whole new HIT industry, and believe me, the big tech vendors already have their strategies and they're already starting to move on them. But what also will start to happen because of this is that you're going to start to see very different healthcare delivery partnerships and payer contracts. So I think it's going to disrupt the whole healthcare business in a large way. And so that will, I think we're starting to see that happen already with some of the movements from the big tech giants in terms of what their strategies are.
And Peter and James, both from a provider, from a delivery perspective, and James also from a vendor perspective on the other arm, I guess, in some ways. What do you all see as the biggest challenges to all of these new regulations?
So yeah,
Peter, would you like to take that?
yeah, I'll jump on that real quick, James. I think from the provider perspective, obviously we're in the process of implementing many of these initiatives that are going to support the program that Julie just mentioned. So we were starting down that path, and then in March, COVID hit. So I can tell you that pretty much all of more of our innovative and our interoperability initiatives have kind of taken a back seat to responding to COVID on a daily basis and all the situations that are involved around that. But we, at Loveless, we've got a number of ways that we're getting started with this to provide that secure transmission and utilization of the clinical patient data, and whether it's between health systems or with the patient themselves. So we obviously we have Epic, and Epic is our EHR, and we're really taking advantage of the capabilities that Epic provides around the Connect, with extending to the community, Epic Care Link, partner to partner type of communication, and then just the I think what's really interesting is the Care Everywhere and the Share Everywhere capabilities with MyChart, and the ability for a patient now to create a code that allows someone else to view their MyChart information and send a note to the chart. So as Julie mentioned, with the consumerization of patient data and what that means, and then put the umbrella of cybersecurity around all of that, and that's kind of where we're headed, I think, as an organization here at Loveless.
And just to kind of build on what Peter's saying, from a laboratory perspective, the medical laboratory is a service provider for the healthcare delivery systems here in the state of New Mexico and all across the country. And so the laboratories, we've had to be interoperable in extensive ways for a long time based on standards, right? Because for TriCore example, there's hundreds of connections and data flows coming back and forth from the lab from all the different healthcare providers and payers here in the state. And so, for us, we see a subset of that data that comes through, the things that Peter and Julie are talking about and how they're having to open up more on the front end with the patient community. From a laboratory perspective, the data itself is something that can really be leveraged to provide higher quality of service from a testing perspective, from an analytics perspective, and information that can be provided back through the healthcare environment, and whether it's through the delivery system or the payer. So a lot of opportunity here to improve healthcare, and not only that, but ability to get information to the right people at the right time to help them with that care.
I think that's really interesting, especially I'm so interested in all the cool things you guys can do with that lab data, which I think has, maybe historically been underutilized in some of these because it hasn't been able to be unlocked the way that you all are doing here and beyond. All of this always goes back to this is all for the patient, and it's for, better patient care and things like that. Cost is always on everybody's mind, but from a patient's perspective, what you just described, how might that impact them, or like what does that look like for them? What's the benefit of that to them? Like what will we see maybe differently when we go to the doctor because of everything that you just described?
So just to kind of build on that, Stephanie, as you build better analytics and insight into the situation for that particular patient, and that's driven off of scientific testing data for that individual. And you get it to a point where it's near real time, looking at the longitudinal patient record within the data to say, well, James went and received care with Julie's system. She went, and then he went over to Peter's system. He got care, and combining that and doing the data analytics and research and providing that back to Julie and Peter and their providers at the right time. That's going to help that provider, that physician, to make clinical decisions when you're coming in for care. A lot of times when you go in for care, that provider doesn't know all of doesn't have a full understanding of everything that's happened with you. So those are things that can help provide support for that provider when they're trying to help you out with your medical situation.
Yeah. Go ahead, Julie.
Oh, I just wanted to add, so what we're seeing now with all of the interoperability standards, so in healthcare, right, in terms of what James has done with TriCore, is that we've always within healthcare had our real-time interfaces, health level 7 interfaces, right? And now what we are moving to are smaller packets of like data called FHIR resources that will allow us to more quickly exchange real-time data in a very focused way for a population and for a patient with TriCore, for example, just as James mentioned. And then what is the big thing that we can do is we can take that data and we can then get it right into the record for the care team on care dashboards so they can follow up on whatever intelligence we have just brought in real time from our various different partners. And so what we're really doing now through interoperability is really having that complete cycle of care with the whole care continuum with all of our partners that are participating.
I think it's really interesting, especially with the way that the consent is structured in our state. And we hear a lot of patients who maybe don't want their information to be contributed to an information network like this. What I'm hearing is that ultimately this contributing your information, giving that consent is going to allow for more personalized, better, more timely care. If I show up at the emergency room, all that information is there. Not only is the information there, but they can provide more personalized recommendations and a better care plan for me. So I think that's really fascinating. That brings us to sort of the other side of the coin about the ownership of data and also organizations being required or mandated or regulated in some way to share that information as we're talking about. So Julie, I will defer to you as being one of the largest healthcare systems, delivery systems here in the state. Do you think that organizations should be required or regulated to share their data in this way? And where do we draw the line between what may be proprietary or trade secrets that make you all competitive in the market?
Well, with this ruling, first of all, when we talk about protected health information for treatment operations, that is covered under HIPAA. So that is shared within the care team because it's necessary to share all of that data currently, and that's been the case since HIPAA. So we share that today in order to be able to provide good care for all patients, all of us do. Now, the thing is, now we have, every health system is required to attest that they do not information block. So we are not allowed to block any information for consumers. That is the big thing that happened with this new final ruling. And there are a lot of other ways that we are now required to attest that we do not block any information with those that need to have it, that who can accept it in a timely way. There are a lot of regulations now that we were supposed to be ready by November 2nd, and as you said, Stephanie, that's now April. But that is a big new change, and it will, I think, allow us to share data more easily, to provide better quality of care and at lower cost, so that we can use these interoperability standards now to exchange more fully and more openly.
Okay, yeah, I think that's really helpful. It kind of reminds me when we were doing our prep call, Peter had mentioned that, you know, a lot of times some of these things kind of end up having to flow through and end up on compliance's desk because there's so many considerations and legalities of it. And to me, I perceive it almost as I don't want to call it red tape because it's obviously very important, but it could also slow or delay things and kind of muck the waters of what we're trying to accomplish, but all the things we need to do to get there. So my question for Peter, since you had kind of mentioned that layer of administration, do you think that rulings like this will, and also, of course, being a proponent for digital transformation, do you think that rulings like this will actually speed health tech innovation, or do you think that inadvertently it could slow things down quite a bit?
No, I definitely think it's going to speed up the the transformational rate that we're at. I just obviously healthcare being highly regulated, it's really got to pass through. I think it was once maybe 4 gates, now it's 5 gates. So it's privacy, compliance, risk, legal, and now cybersecurity. I mean, cybersecurity cannot be an afterthought like perhaps it was in the past. Today, cybersecurity is up front with everything else we do. In other words, what data are we collecting? What data are we creating? What data are we sharing with our partners, et cetera? And then how are we protecting that? And how are we encrypting that? And how are we making sure that that patient data is being used in the way that it's intended? And then how do we protect against all that? So yeah, it's but I think we're being driven by this by the consumer demand for data share, for et cetera. So yeah, I think the example that was provided before, where if we have our community partners participating in Care Everywhere, for example, clinical information is received almost instantaneous, goes right into our records. So you show up at the ER, and we can see your medications, allergies, immunizations that exist outside of the Ardent or Loveless Epic system. And I think that's really important to provide quality care. So yeah, it's to me, this is going to be the kind of the new norm that we operate under as we continue to really consumerize the care that's provided. And you see all the examples today that we're doing around telehealth, e-visits, that whole digital front door situation where we want providers and patients to interact virtually. So I'll just kind of say that this is going to continue to drive that innovation, I would say.
I think it's interesting. Just a minute ago, we were talking about patients consenting, and allowing their data to flow in the system. And now we're moving more towards, of course, the providers consenting and letting their information flow into the system and share it as well. So with that, I'd like to turn to James, because you all are at the forefront of trying to bring what information we already have somewhat aggregated, adding more in, and starting to do some of these innovative things. While it all sounds very utopian in concept, there's still a lot of challenges. And so I'm curious, from your perspective at this early stage where we are, what do you see as still the biggest challenges or the hurdles that we'll need to overcome to get to that kind of ideal state that Peter just described?
Well, I think, there's been a tried model, with health information exchanges in the past. And I think with this these changes that Julie and Peter are talking about, it actually opens this up even further than just trying to go and centralize data and then go get it. It instead of that kind of a hub and spoke model of data, really what this does is start to create a mesh type of concept, as organizations start to partner and work together. So I do think that there's it's going to get a little more complex, and in order to basically get in, and what that means is that the biggest challenge I think will be about standardization. How do you get data formats and data models to match up and map and all of that activity? Because I don't want to speak for Julie and Peter. They both run off of Epic, but they may not be coding information in their electronic health record in the same ways, right? So as you start to bring data together, trying to understand a map so that you can get that consistency and get that understanding and be able to use it effectively.
It's about the way we now document cleanly, right, James? Because
Yeah.
we have the standardization, but now we have to make sure that the way we document is very clean and appropriate. Okay, so when all of us were ready to go live with providing much more information into our portals for Peter and me, that's my charge. What you are doing is you're providing everything to the patient as of November 2nd. In most organizations, they had lots of provider teams looking over to see how, now that the patients have that facing to them, is our documentation, how good is our documentation, right? And so that's what you're really referencing, and that all of that will really help, because for James, for you really need that clean data, right? To interpret.
That's true. It's a little bit like spaghetti sometimes, right? That bowl of spaghetti trying to
Yeah.
Well, that's giving it more credit, I think.
Yeah, exactly. Who, what means what, where, when, why.
Yeah.
Right? So.
Well, that's interesting, Julie. We talked about, the TEFCA framework, and you mentioned FHIR earlier. In theory, these should be standards to abide by, yet they're still falling short in some ways. So despite having these standards like FHIR, where do you think those fall short, and where could those be improved upon to make things more standardized and more clean?
Well, part of the ONC 21st Century Cures Act, if you're an HIT developer, you need to be certified. So there are now strict certification rules in terms of adhering to FHIR, adhering to authorization requirements, adhering to testing. There's a big requirements in order to get certified. So you can't just have health information technology out there and have it not be secure, have it not support the kind of data sharing requirements that Peter mentioned. So that was part of the greater than 1,000 final ruling, I think over 1,000 pages, is the increase in certification requirements for HIT developers. And so it is, this is not kind of a laissez-faire thing anymore within healthcare. And so this is major. If you are a health system and you're developing your own within your own environments, the APIs, you do not have to go through the certification requirements. But the moment you extend it to others, then you do.
Interesting. Okay. Well, I think, oh, was that?
I would just say something real, so yeah, Julie, you know, what we here at Loveless, whenever a new solution comes in the door, or we're vetting a certain application, you know, the first question we ask is, are you in the app orchard? Yes or no? Oh, you're in the app orchard. Okay, good. Then that speeds up our governance and vetting process. The app orchard is kind of this authorized and endorsed set of applications that can be used with Epic, within Epic, for example. So there's that, and I thought that was kind of interesting. It's like every time we look at something, oh, you're not in the app orchard. Okay, now we really got to take a look at you.
And they have to do it, and it's a long process. So every EHR vendor needs to go through certification.
Yep.
I know
and their apps do too.
It's funny because, you know, as much heat as Epic, you know, I was trying not to name any names earlier, but as much heat as Epic kind of comes under, you know, it's interesting, Peter, you mentioned the app orchard, which has kind of gone up and down in its development, I guess, but, you know, still being looked to as the gold standard. And now it sounds like even doing some pre-vetting for vendors. But, you know, from a vendor perspective, I think that's interesting because it's very costly to get into the apple orchard, you know, very well-established vendors, which is good. But I think from a, you know, if you're a digital technologist and maybe you're new into healthcare, like some of the attendees we had last year at the experienceIT, you know, it's not always feasible for folks to get into something that big that quickly. So I think it's just an interesting time, I think, as we're talking about innovation, you know, from top to bottom, big to small, you know, new technologies to legacy technologies. So I think that's interesting.
Not a question anymore. Okay, you cannot not do it. Okay.
Yeah.
Epic just has a program to facilitate those vendors who are going through it to do it in their methodology to help them with integration with their own system. And I'm sure the other EHR vendors have also programs to do that.
Yeah, or they need to, absolutely.
Yes.
Yeah.
That's so funny, you know, from a vendor perspective. I have this, you know, sitting on my desk, you know, the app orchard.
Okay.
Was I off on the cost prohibitive perspective?
I didn't want to get us off the rails here, but you know, every day, you know, we're provided you know, some startup or some blockchain company that wants to come in and do business with us, and you know, the risk, I'll just say risk aversion towards, you know, trying something new that's not been thoroughly vetted is, yeah, there's, I'm sure there's an investment cost for that.
Yeah, and I mean, I think that directly influences the speed of innovation that we're talking about, because with all this AI and all these really new next generation technologies coming out, they're relatively new and especially relatively new to healthcare. And so they may fall into that bucket, Peter, that you're talking about, unless it's developed by a, you know, a huge organization, which, you know, sometimes you get great technology coming out of MIT startup or something like that. So I think that's a great segue into our next realm of questions, which is really, we talked about what's happening now, where things are going. I want to talk a little bit about where we think we could go. In an ideal world, I really would love to hear from all three of you. You know, what kind of technology or innovation or new concept or technology are you most excited about given all of this? Let's start with Julie, go to Peter, and then James.
You know, I guess I am probably most excited about the electronic health information. Health systems can either get in it or stay away. But really what we're talking about now is an interoperability strategy to support consumers. And when you're thinking about consumers, maybe changing your perspective from being focused on really health to really broadening your concept of that into wellness and what that's really going to mean when new HIT companies start up providing more wellness services that you can integrate with your current care continuum. I think that is really exciting. The other piece that really gets me going and very excited, and it probably sounds a little bit weird, is that I am really passionate about bringing in external data in real time from all of our different partners so that I can get it right back into the record and the care team and the patients so that we can have immediate action on follow-up care. I'm very passionate about that. And what that will actually do is decrease the cost of healthcare too, and the administrative cost, particularly when you're thinking about how you need to coordinate activities between your payers and providers. So I'm really very excited about the opportunity now to get everyone coordinated and working with more of an integrated care delivery workflow across the continuum by really leveraging technology solutions, never leading too fast with technology, but definitely supporting now in terms of providing more efficient and more access to care.
Great. Peter?
Yeah, I would say it's the the concept around Internet of Medical Things, right? It's remote sensing. It's being able to collect vitals and do vitals monitoring remotely. Bringing in Fitbit data into the equation. All of the kind of that lifestyle characteristics that can be brought into into the care program based on sensors and remote monitoring and in the home and as part of your lifestyle, right? Whether it's sleep patterns or your diet and all of A1's, all of those things that can be brought in, I think, through remote sensing and remote capabilities and those external sources, I think would be are what's really interesting to me also.
Yeah, I thought you would say IoT or blockchain. I was 50-50
No.
on what that might be. Abandoned blockchain. Great. All right. And James, what about you?
When I think about this, I think one of the things that really excites me, I'm going to go back to something that Julie said, is that, in healthcare, if you compare healthcare to other industry verticals, manufacturing, finance, what have you, the technologies, from an IT perspective, we have all the tech, right? And there's a lot of great stuff going on out there. But when you start to get the regulatory and compliance items in place so that you can really start leveraging that IT, which is really what we've been talking about today, then that really opens things up. And what Peter's talking about on the front end, whether it's your Fitbit or Apple Watch and the data coming in, I think one of the more exciting areas is going to be in the data science back end, right? And so if you're sitting on this call, right, and you're just entering IT, and you're thinking about where do I go, with my career, you should strongly consider studying more about how you use and manipulate and work with data, right? Because the connectivities and the things that were being built, there's a lot of people out there bringing that in for our use. But how do you take that data and really analyze and make value out of it in a way that a person can use it effectively? And so I think that that's really an exciting area for healthcare, because as that gets built, as that becomes more robust, that it will in turn drive even more tools and automation, and it really will help providers provide care, and that's what it's really all about, right? Is take care of your family and your providers helping you with that. So
Yeah.
I think that's exciting.
Yeah, I'm happy to hear you say that. I think definitely here in New Mexico, we we can use as many data professionals as possible. Data science is such a new and exciting field. We're getting all kinds of cool boot camps and crash course type things, even for upskilling. So yeah, really happy to hear you say that, because I think even no matter how great we can bring all that data together, like you said, that spaghetti's still going to need some straining or something. So, I don't see that going away anytime soon. That's somebody from, coming from someone who lives with that day in and day out. So I got to say, you guys are great panelists. You're teeing up all my segues, so all these great questions. And James, you just segued right into what advice, we would give for either aspiring healthcare technologists or fellow vendors or fellow healthcare CIOs. And so you already mentioned a little bit about from the career and skill set perspective, but let's go in reverse order back up. I'd love to hear from all of you. What advice would you give to our audience, who probably largely comprised of folks who either have a new technology idea or maybe work in traditional IT, and maybe aspiring CIOs, things like that, trying to get into healthcare, of course.
So, Stephanie, I'll just kind of build on what I said, and I'll hand it back, I guess, to Peter. But we're really blessed to be living and working in the state of New Mexico if you are interested in working in health IT. Why? Because there's not a lot of places around this country where you get the level of partnership between all the different major health systems, the laboratory, and there's just a lot going on here that we work together on in the state, and that's really important. So if you're just getting into IT, if you're early in your career, stay here. Stay in the state of New Mexico. There's a lot of opportunity to grow your careers here. There's a lot of opportunity to improve healthcare, not only for the state of New Mexico, but for across the country with the work that you're doing. So that'd be my advice. Study, there's a lot of opportunity to learn here and to grow your career, and it's just going to continue to grow as the state goes along.
Peter?
Certainly, I think it's interesting that, IT is involved in everything we do in healthcare. Every encounter you have involves multiple touch points and layers. If it beeps, if it lights up, if it makes a sound, if it, everything is considered IT or biomed perhaps, but if you look at the technology that's behind every one of your encounters, it's staggering, really. It's in terms of what it takes to support that and to develop within those systems. So I would say that, we know that, for example, Press, Loveless, Christus, there's systems within New Mexico that are on the Epic platform, and we're always looking for Epic developers and those that can, an Epic analyst that are on that platform that can work within those. Every day we've got new builds going on in Epic, so that's an area, and you can get into that. I see Renee Moya's on the call here. Renee sent, we use staff that are start off at desktop support. You get that experience, working in the clinics and in the clinical environment, and you start to learn the workflows and how that goes, and then you can actually build. We've got some great career paths around. I'll just say Epic development, for example. So that's one area. Data science certainly is going to continue to grow. And yes.
That's great. Julie?
I think James and Peter's said a lot of, really focused on a lot of the important points. Data is everything, right? In terms of how we manage it, maintain it, provide access to it. And so the where we've been is kind of with an analytics focus a lot of times, right? How to make data intelligent, and then how to make it actionable. So data scientist careers, that is super important. I think now really where we now are going to be taking off in a really big way in healthcare is in real-time interoperability knowledge. between these core transaction systems. And when I'm talking core transaction systems now, I'm talking across the entire ecosystem of healthcare, because payers are now getting into the real-time exchange as well, which is kind of a new thing for them that they haven't been. In addition to that, it is the API development expertise that we now need. Every organization needs it. And then third, I think what we're now really starting to see is that our healthcare businesses will change incredibly, right? I think the delivery system with telehealth, you're going to see geography fences coming down. I think you're going to see, as we get into the home, as we think about how we can deliver additional services without the kind of distance issues we've had in the past, that will open up a whole lot of new businesses within healthcare. I think for IT, like Peter said, we're in everything, right? We have to know all the workflows. So there probably is not a better time to be in health IT, because it's going to just grow exponentially, and we're at every single table.
Definitely becoming multidisciplinary. You have to know the business of healthcare really well, as well. And I would say the same for a good data scientist or a good analyst in healthcare. Makes a huge difference. Well, we have about 1 minute left. So I have a pop question, and whoever wants to be brave enough to answer it. But who do you think owns the data, the patient or the organization?
Patient.
Patient. Okay, great. That's unanimous. Well, thank you, everybody. We're right at the top of the hour. If you have any other questions, I'm sure our panelists would be open to answering things offline and potentially considering another New Mexico HIMSS panel of the same. So thank you, everybody, for joining, and let us know if you have any follow-ups.
Thank you. That was really informative.
Great. Yeah, it was great.
you.
Bye, everybody.
Goodbye. Thank you.
Thank you.
Thank you.
Okay, that was amazing.